Okay, so we're ready to start our annual lecture, and it gives me huge pleasure for the first time to introduce our Vice-Chancellor, our new Vice-Chancellor, Stephen Toope, who has been here since this academic year, and we welcome with great enthusiasm. I have to say, your inaugural address was absolutely inspiring for us as a community. So Stephen's history is in human rights and public international law and international relations. And of course, he's got a strong university, has run universities before, but I think his academic background is one which is of huge interest to us in public health. And of course, we've touched on these things right throughout the day. So, Stephen, can I invite you to welcome Flavia?
Thank you very much, Carol. It's really an honor to be here. And I have to say, I specifically chose to come to this event, in part because we have a very distinguished speaker. Sadly, I'm not going to hear you because I have to run off, but also because I really wanted to say to you as a community how important I think global public health is, and public health within the United Kingdom, of course, but global public health is for the University of Cambridge going forward. I, some of you will know, have spent the last almost 3 years at a School of Global Affairs. And I'll be frank and say that one of my greatest frustrations in that role, it was a great role and I had wonderful colleagues, one of my greatest frustrations was that there was actually no integration of global public health into the work of that School of Global Affairs. And frankly, it made no sense to me. Turned out for very complicated reasons that that was not going to happen, at least in the short term. But I very much hope here at Cambridge that we have an opportunity, and I think we do, to treat global public health as a core element of what we want to do with the wider world. So I leave that to you to figure out how best to achieve that, although I want to talk with all of you about that over the course of the next few years. I know that you've already had a very long day. You don't want to hear from me. You want to hear from our distinguished speaker. Let me say that we're simply delighted to welcome Dr. Flavia Bustreo to Cambridge to deliver this year's keynote lecture. Dr. Bustreo, as many of you will already know, is the former Assistant Director General for Family, Women's, and Children's Health at the World Health Organization. She began that role in 2010 and has only just finished that role. So our Octobers are very important. I've just arrived, you've just left, but we're thrilled that you've joined us as one of your first activities after that role. In her role as the Assistant Director General, she provided guidance and oversight on matters which are absolutely critical to the promotion of health throughout the life course. She oversaw work in 5 technical areas: aging and life course, maternal, newborn, child, and adolescent health, public health, environmental and social determinants of health, immunization, vaccines and biologicals, and reproductive health and research. And I can say, wearing my former hat and my former hat as a Canadian, that the work on child and maternal health that she undertook was absolutely stunning in its influence globally. Her work focused, of course, on policy development as well, concerning child and maternal health, policy implementation, and partnership building across a diverse range of stakeholders. And having done some work within the international system at the United Nations, I know how complicated that is. Dr. Bustreo led the development of the Global Strategy for Women's, Children's, and Adolescents' Health, which extends right out to 2030, and she contributed to the high-level task force on international innovative financing for health systems, absolutely crucial, of course, and to the United Nations Task Force on Millennium Development Goals 4 and 5 to reduce maternal and child mortality. I think we're very, very fortunate to have you here to reflect on an absolutely central issue in global health. Her talk is titled Health Across the Life Course, Unlocking the Potential of Women, Children, and Adolescents. Please join me in welcoming Dr. Bustreo.
Thank you so much, Stephen, Carol. I'm absolutely thrilled and honored to be here with you to actually follow on the footsteps of giants in public health. My mentor and the person that I have admired for long, Professor Julio Frank, that delivered the keynote lecture in 2015, and also the Chief Medical Officer of England, Dr. Sally Davis, who are known and worked for a long time, including in my role as the World Health Organization. I have to admit, I also feel a bit intimidated coming at the great Cambridge University, and when reading the history of the university, the one thought that came to my mind to share with you and to come close to you is particularly with the students that are studying here in Cambridge University. This is one of the oldest universities in the world, but my alma mater, that is called Padua University, is actually in the same league. And in fact, if I read on the internet, if that is the standard of evidence that we have these days, that Cambridge was actually founded in 1209, and Padua University was founded in 1222. So this is some of the commonalities that we have that no doubt will shape your way of thinking and have certainly shaped mine, being able to study in university that have this kind of historical knowledge and historical background. And for the students that study here, being able to study with the understanding of giants like Newton and Darwin. And for me, it was studying with the giants and the image and the presence of distinguished scientists like Copernicus and Galileo. And it's, I'm talking with you and to you today on the shoulders of those giants that have preceded us. And I have entitled the speech and the lecture, Health Across the Life Course, Unlocking the Potential of Women, Children, and Adolescents, not just because it's my life passion, and not just because it's a topic that we also discussed last week with the health ministers of the G7. You were just discussing at the panel how to influence policy and to make sure that the political actors, they take the right decision. But also because I sincerely believe that is an area that can be a driver for the broader public health work. And I want to use it as an example of how the broader public health work can take us to the future, which is the theme of the day. Before I begin the speech, I have a little help. I would like to share with you all the video that was shared with health ministers last Tuesday in Milano. The Minister of Health of the G7, including UK, and the Commissioner for Health of Europe. They saw this, and we had some discussion after that. I can assure you the discussion was very short, so the discussion here will be much longer. Please.
Every woman, every child, every adolescent. If all the world's women, children, and adolescents are healthy, the odds are good that everyone else will be too. That's why in 2010, the United Nations launched the Every Woman, Every Child movement and a strategy to mobilize and intensify actions taken
by governments, businesses, civil society,
and by the United Nations and other partners.
Actions to end preventable deaths among women,
children,
and adolescents.
And to do it soon, within a generation. The effort is building on progress already made. Since 1990, maternal deaths have dropped globally by 44%. The death rate for children under 5 is less than half what it was then. And since 2000, the adolescent death rate has fallen by about 17%.
The global strategy also focuses on improving the quality of our lives, so we can thrive and help transform the world.
By making sure girls and boys have the care, love and support we need to be everything we want to be.
Yes, and you'll see that that can take many forms as you grow up, from healthcare to empowerment. Ensuring access to sexual and reproductive health services and rights for everyone, everywhere. Progress is not always easy in a world where setbacks from war, climate change, and epidemics are common.
So what can we do to make sure progress is happening?
The movement is mobilizing support for women's, children's, and adolescents' health. It's also bringing partners together to look at what's been achieved and what can be done better. Ministers of health from all over the world have committed at the World Health Assembly to take forward the implementation of the global strategy and report on progress. Toward that end, the World Health Organization has created a data portal to keep track of what's working and what's not.
Don't we already know what works?
Big knowledge gaps exist, but by building on previous successes, we've gotten a big head start towards reaching global goals.
I learned about them in school. Goals like ending poverty and protecting the planet and making the world a better place.
Yes, and goals like ending child marriage, because girls who marry are less likely to finish school and more likely to suffer complications or even die during pregnancy or childbirth. They're also more likely to be poor when they grow up.
I studied that too. 14 of the countries with the highest rates of child marriage in Africa are taking steps to end it. That's good for everybody.
Every Woman, Every Child partners are supporting these and other programs, like training midwives, improving education and nutrition, and providing community counseling and better access to clean water and sanitation. In the last 2 years, low and middle-income countries have pledged nearly $9 billion. In all, since 2010, partners have invested more than $45 billion.
The health and well-being of women, children, and adolescents are improving faster than ever before.
So the problem is solved.
I wish, but no, there's still much to be done. In 2015 alone, more than 300,000 women and girls died from preventable causes during pregnancy or childbirth. Nearly half of all women who gave birth received no postnatal care at all. Nearly 5.6 million children under 5, that's 15,000 a day, died. And 2.6 million, 7,000 a day, were still born. Most of these deaths could have been avoided.
That's not fair.
No, it's not. But we can all help. It's our future, and we all must do our part, so that women, children, and adolescents can create a better future and help transform the world.
Together, we can make a difference.
In a small room, without the possibility that the journalists would observe them or would hear them, and with a table where only the ministers are sitting. It's almost as intimidating to speak to them as it is here this evening. But most importantly, in my experience, having the opportunity to exchange, even if briefly, with some of the evidence, but also presented in a way that is not boring or is not maybe the usual way that we present it in the Lancet or in the British Medical Journal, can be effective. So my talk is structured in 3 parts. The first part, I will elaborate a little bit on the history of what has enabled us to arrive where we are, at the history of the global strategy, the actors that have contributed. The second part, I will look mostly at the current challenges that are facing women, children, and adolescent health. And in the third part, I will elaborate further on potential solutions that I like to maintain and discuss with you, particularly with the young people that are in the audience. And I'll identify them up front. They include universal health coverage and the life course approach that I know very much is close to your interest and close to the interest of the school. So let me start with the first part, which is, please forgive me, in fact, I should have asked you, please give me a signal after 10 minutes, because on this part, I can talk for hours. It was sometime back in 2003 And some of you might have recalled that, and I was just having a conversation with you, but there was a very interesting publication that appeared in the Lancet that was entitled the Child Survival Series, the first Child Survival Series. And that was a publication that showed for the first time that actually in the history of the world that we were observing not continuously reducing child mortality rates, but in fact, because it was at the peak of the HIV epidemics, that in fact, in some sub-Saharan African countries particularly, we were observing increasing child mortality rates in countries. And that publication had a tremendous impact, having been part of the group, together with Professor Victoria from Brazil, Professor Bryce from the United States, Professor Betty Kirkwood from the London School of Hygiene and Tropical Medicine. It garnered the world attention, including the attention of actors like, for example, UNICEF, that for the previous 2 decades had been at the forefront of the effort like the Child Survivor Revolution. I'm sure that the professors here in the room will remember, but maybe for the younger people, you could read the history and see that from the 80s to the 90s, particularly during the leadership of Jim Grant, the inspiring leader of the UNICEF at that time, the world had driven a significant reduction of child mortality. And in fact, it was called the Child Survivor Revolution. And I was laughing a little bit this morning when at the beginning of the presentation, there was the issue of the magic bullets. Because at that point, that Child Survivor Revolution was actually driven by some belief in some magic bullets and what was called the GOBI, that was growth monitoring, oral rehydration, breastfeeding, and immunization, as those were considered the so-called magic bullets to reduce child deaths. And indeed, they had driven significant reduction. But 2003, the attention of the world had disappeared to this problem. It almost was like, okay, this was something in the past, it was done, and we started seeing child mortality rates going up. I can tell you, Carol, that one of the actors that was very instrumental in garnering the world's attention was definitely Richard Horton. As the editor of the Lancet, not only gave space for the group of us writing this and writing a call to action, but also he did something very naughty, very Richard style, which was he wrote in his editorial some attribution of responsibilities. And he wrote attribution of responsibility to organizations like UNICEF, like WHO, like the World Bank, that had dropped the ball. And sometimes attribution is also useful. Evidence is important, but there is the need to shake the interest, and attribution of responsibility can make a difference. And from that publication, we also created something that was called the Countdown to 2015, which you might have seen, that was tracking the progress of maternal and child survival from that time up to 2015. And the first time that we published those data, particularly on the coverage of those interventions that are important, we actually did it here in the United Kingdom. We worked together with, at that time, Professor Haynes, the Dean of the London School of Hygiene and Tropical Medicine. That is my other alma mater here in the UK. But we did it with, we had a large conference, and we had very senior policymakers, including Princess Anne, including ministers, in order to bring to their attention these facts and how, in fact, the coverage of those interventions that were needed to improve child health and reduce child mortality, how they were not happening. And one of the key things that happened was also we were able, because of this keen understanding and renewed interest, and also because of the shaming of some of the actors, we were able to create a coalition of actors that actually brought together several different ones. I remember very well discussing with Carol Bellamy at the time, the leader of UNICEF. UNICEF suddenly became very interested in doing something and recuperating the time. And we were able to create what then became the Partnership for Maternal, Newborn and Child Health, which brought together different groups that were focused on the health of the mothers, the Safe Motherhood group that were focused on the health of the newborn, and also groups that were focusing on the health of the child. And that assembly of partners began a journey of raising public attention and garner collective action, in the word of Julio Frank, that in fact in 2010 became the chair of that Partnership for Maternal, Newborn and Child Health, which is the time during which my association with him became so intense and strong, and for which we are extremely, extremely in debt, because he played a key role in creating the arguments that in 2010, in fact, led to a big transformation. And I'm glad that the Dean referred to the work with the Canadian policymakers, because 2010 was a transformative year where the arguments that were built, the investment case that were made for shaking policymakers, investors in health to action, actually, finally, almost magically came together. And I think in your panel, you, Carol, were actually saying sometimes persistence is very important. The message is not necessarily heard right away. And that is indeed my experience too. So why 2010 was so special? Because under the Canadian leadership, at the time it was actually not the G7, it was the G8, because the Russian Federation was part of the group. We worked with the Canadian government to forge an initiative that was called the Muskoka Initiative for Maternal, Newborn and Child Health, that garnered the commitment by those G8 countries, not just in words, but also in resources, with more than 10 billions that are still being spent in countries with the highest maternal and child deaths. And it wasn't just the G8, but it was African Union. In fact, at that time in Kampala, I was just remembering with Ross, one of the last fun time I was in Kampala, the entire African Union heads of state at the summit that was entitled Maternal and Child Health and Development in Africa. And they committed to their agenda of transformation and addressing this important problem. And the Interparliamentarian Union, that is the assembly of the parliaments of the world, also had a resolution that was precisely addressing this. And working with the Secretary General at that time of the United Nations, Ban Ki-moon, we launched the first global strategy for women, children, and adolescents in September 2010. And at that moment, there were commitments that totaled to more than $40 billion from civil society organizations like Save the Children, like World Vision, from pharmaceutical companies like Merck. They created their initiative that is now known and called as Merck for Mothers, and many, many others. But the mobilization, what we have been calling for, what we have been advocating for, finally was coming together. So we zoom from 2010 to 2015. 2015, for the professors that are here in the room, they will remember very well, that was the time when the Millennium Development Goals were ending. And so there was a strong effort of analysis and a particular effort of accountability to track, have we actually reached these Millennium Development Goals or not? And for the Millennium Development Goal 4 of reducing child mortality and 5 of reducing maternal mortality, you have seen in the video, the progress was significant, but actually they were not reached, those goals. So, as you have just seen in the video, there is still a huge unfinished agenda that is actually even more interesting and appealing, at least to me, but I hope that at the end of the talk will be appealing to you, and particularly to the young students, which is not only to look at the survival of women, and particularly women during their maternity period, and the survival of the still 5.6 million children that lose their life before they're 5 years of age every year, but also to look at how can they actually thrive, how can they actually become actors of development, and how can we use the period of reproduction and the early phase of life as the moment in which our health capital becomes consolidated, and we carry that health capital throughout the rest of the life, despite the incredible numbers of risk factors that are around us. And the day today was very rich in illustrating all the risk factors, from the social risk factors, the kind of work we have, the environmental risk factor, the kind of air we breathe, the kind of water we drink. And so thinking about how can we have this integral part of the population that public health is really catering for, how can we have this population become actors of development and successful in thriving? So let me move to the second part of the talk, which is what are the challenges to, how did I meet? Dead on? Oh, we didn't speak, but this is a great collaboration, I can see. So what are the challenges that we see in order to achieve continuous progress in reducing deaths, improving health, and transforming the lives of women, children, and particularly adolescents and young people? I will speak more about them in the next part. What are those challenges? I think the day today has simplified my talk tremendously, because we have clearly seen that in order to realize their right to the highest attainable standard of health, currently in many parts of the world, including the UK, unfortunately, including my own country, Italy, unfortunately, there are several determinants that actually prevent women, children, and adolescents to enjoy the fullest right to health. And the biggest, when I think about what is the biggest determinant, is actually poverty and deprivation. And poverty and deprivation, why? Because we see, and we have data, in fact, that when we looked at what we called, we published in 2014 with Professor Kuruvilla, one of my greatest colleagues, we looked at what we call the success factors for reducing maternal and child deaths. So we did a retrospective analysis of the 10 countries that actually were on track to reach the Millennium Development Goal 4 and 5, and we did an analysis of what were the factors that enabled that to happen. And we saw that in each of the countries where that progress had happened, progress on the poverty, reduction of poverty, was one of the key factors that in fact enabled the improvement in health. And of course, that was not the only factors, but other factors, what we call the social determinant of health, for example, education, particularly girls' education, was a very strong link and a very strong success factors, as we call it, to make it sassy and understandable by the policymakers. But also gender inequalities and the improvement of that gender inequalities, women participation to political participation. Like, for example, in the case of Rwanda, we saw that in the years during which there was a significant transformation of political participation of women, and particularly Rwanda is currently one of the countries with the highest proportion of female parliamentarians, which is far higher than the UK, far higher than Italy. And we saw that there was an association between that political participation of women in the policy making and the decision, for example, of making maternal care free for the users. So these are the determinants that have enabled the progress in the past, but that unfortunately they are still a big challenge, because unfortunately in many countries, including the US, as you have, I believe the proportion of women parliamentarians in the US is around 13%, if I'm not mistaken. So These are big challenges that I think public health alone cannot answer. These are big challenges that public policies have to find. And that's why collaboration across different disciplines is so important. Of course, the environment is a huge challenge, and I think you have discussed today the importance of a phenomenon like air pollution that we have seen while I was in Italy with the ministers of health in Milano. There was a big scandal because the quality of air is almost 100 times above the level of the standards that are recommended by the World Health Organization. And that was very visible, the smog and the pollution and also the feeling that people had. And Milano is not the worst. Delhi is actually, I've been quoted in so many times in the Indian Times, in the Indian newspaper, because unfortunately Delhi has this incredible primate that is the most polluted city in the world. And you have seen that the government was forced to close the schools, and which of course is not a sufficient policy decision. But the environment, the air we breathe, particularly in their indoor air pollution, has a negative impact on women's health, because women, especially in the middle and low income countries, they use traditional form of cooking, traditional form of eating, and therefore they inhale pollutants. But also, these, for the very same token, also children that are around women and that are in the household, they are also, their health is particularly damaged, is impacted by the quality of air that we breathe. And climate change. While we are here in Cambridge, the policymakers of the world are meeting in Bonn, discussing the follow-up to the climate change treaty in Paris. That's one of the things I actually am maybe most proud of my work with the World Health Organization was in 2015, in the lead up to the Paris Treaty, we were able to lobby, because really it was an action of intense lobbying, to ensure that within the Paris Treaty, the right to health was recognized. And together with Dr. Chan and with the colleagues in WHO and with Mary Robinson that leads the Foundation for Climate and Justice, we were able to articulate clearly the links between climate change and the direct impact of climate change on health. And we were also able to articulate the importance that the treaty, binding instruments, I'm sorry, the professor is not here, but legally binding instruments that this treaty would recognize that association and would also recognize the right to health. And we fought very hard and we achieved it. And it's because of that that this week, Dr. Tedros, together with my colleagues, they actually have announced a new initiative together with many partners looking at the impact of climate change on the health, particularly of the small island developing states, because climate change impacts health across the world, but unfortunately, the island states are probably the ones that are the least capable, that have the least resilient health system, and are the ones most impacted by the terrible phenomenon that are associated with climate change, heavy rain, disappearance of the islands. So this initiative hopefully will drive resources, because at the moment, if you look at the climate change financing that was promised in 2015, the so-called 100 billions that were promised for addressing climate change, adaptation and mitigation for health is a very small sliver of that funding. And unless and until collectively we are able to change that, then it will be very challenging to actually address those determinants of women, children, and adolescent health that we are here discussing. But there are other determinants that are also, other challenges that are also, that I like to mention, that include, for example, prejudice and discrimination. And I'm particularly referring to the disruptive social change and the new pattern of migration that we observe, certainly here in Europe, but also in many other parts of the world. Still to this day, Jordan is the country that hosts the largest number of refugees within their own national boundaries. But for us in Europe, sometimes we feel like we have this pressing migration. Certainly I know in Italy, for example, this is a topic that is absolutely very central in the public opinion, and there is a lot of prejudice about will the migrants bring new diseases? Will they disrupt our social order? I'm just telling you the question that the journalist asked me last week. So I'm not exaggerating. This is what they ask. Is the fact, for example, that in Italy, for the first year in 2017, we saw a large outbreak of measles. Italy is the second country in Europe in 2017 with the largest number of measles cases, more than 4,000 measles cases, of which 4 deaths, which is unprecedented. But the climate among the public and the journalists is this because we have the migrants? And in fact, all epidemiological analysis evidence shows that the cases are among the Italians, they are among non-vaccinated children and adolescents, and that they are closely linked with the decision by many, many parents not to vaccinate their children because they are listening to what we public health do not call evidence, but what is now called the fake news, what is circulating in the social media, what is the few cases where there have been some side effect of vaccination. So this discrimination and also disruptive social changes is a big challenge. And in fact, what we have seen is that as the number of maternal and child deaths is decreasing in the world, we see a concentration of those deaths where? In the countries that are in conflict, that are emerging from conflict, where we have displacement and movement of people. And so this is a challenge, is a particular challenge, again, that is maybe beyond what we can do in public health, but that has clearly a huge impact on health of women, children, and adolescents. And of course, I also want to mention as challenges, particularly for the future, the emerging threats of epidemics, including new epidemics. In 2015, we witnessed, and my team, we had to really fight hard. You will have seen the epidemic of Ebola and the tremendous consequences it had on the number of deaths within the 3 countries in sub-Saharan Africa, but also across the world, the fear, again, the prejudices that were appearing in the media and among many policymakers. And one of the things that my team and we were able to do very quickly in the space of 1 year was to develop the first vaccine against Ebola. And so now, today, if there was another epidemic like that, we would be able to use a vaccination that we were able to test during that year. But Ebola was one, but during the time at the World Health Organization, I witnessed, for example, new epidemic like Zika that has a very pernicious effect, particularly on women and children, because when we know that the virus that is a very neurotropic virus that damages particularly the brain of the fetus and results in either microcephaly at birth or even in children that are normocephalic, they still have a damaged neurological development. And this is what the study is currently showing now in Brazil. So these emerging threats, some of them are linked to the climate change, are linked to the diverse and different and new biology and epidemiology of vectors of diseases. But also, I'd like to mention the emerging threats of non-communicable diseases. And I think today you have alluded to diabetes, hypertension, and the discussion was very rich today. It's also the World Diabetes Day. But these conditions impact health of women in a very particular way. For example, in the last publication of the causes of death, maternal death, we saw that actually a significant increase of what we call the indirect cause of the maternal death. And those are causes linked to gestational diabetes and hypertension, particularly eclampsia and preeclampsia. So we see that this rise of these conditions associated with a delay of the age of first pregnancy and first delivery, that the causes of maternal death are changing. And clearly the response has to address, for example, obesity in adolescent girls, because we know very well that an obese girl has much more difficulties when she becomes pregnant, and she can have complications of that pregnancy. So I hope I haven't painted the picture too bleak, because that I'm moving to the third part of my talk, where I would like to elaborate with you on some big ideas that have emerged in public health, in global health, that I think they have a lot of potential for addressing those challenges and for enabling women, children, and adolescents to really not only survive but also thrive in the future. And I'll start from universal health coverage. I know, I'm looking at you because I know how intense the conversation is in the United States about Universal Care Act and the universal coverage. And yet it's not universal, but still. Now, in the Sustainable Development Goals, universal health coverage is a specific and direct target. And in the words of Dr. Chan, with whom I had the pleasure and opportunity to work for almost 10 years, she said that universal health coverage is the best concept that public health has to offer. And I think the battle about the concept and how valuable it is for improvement of health and for reducing of inequities in health, I think that battle has been achieved. What I think is now, we are now at a stage where we need the political will for reaching it. And I was delighted last September when traveling with the new Director General, Dr. Tedros, that at the biggest event that we had this year with several heads of state, he talked about universal health coverage as the center of gravity of global health. And he also said specifically, women and children and adolescent health are the center of gravity of universal health coverage. And why did he say that? Because clearly, if our health systems are not able to offer those services around reproduction, the basic services of immunization, of treatment of a common childhood illness, pneumonia, diarrhea, measles, if the health services are not able to deliver those, clearly we cannot have universal health coverage. But the key aspect of universal health coverage that is often forgotten or intentionally forgotten by policymakers, including from my own country, is the importance that the universal access is reached, including financial protection. Because we could have, in a world that is not the ideal world, we could have universal access, but if people have to become poor in order to access health services, as we see in many countries of the world, that is not the concept that public health has to offer. That's the concept of universal health coverage is truly access to services and financial protection from the access to services, which doesn't mean necessarily that there has to be a national central health system like the NHS or the health system we have in Italy doesn't mean that, but in the words of Professor Frank, is not, what has to be public is not the provision of the services, but is the financing of those services in order to have financial protection. Because if not, then the people that are the richest, they will have different quality, they will have access to different quality services. So these two aspects of universal health coverage, I think I invite the school and Cambridge University and other to really work, because for public health, I think for public health officials, we are very comfortable, and we have all done tremendous amount of studies on the epidemiology, on the quality of services, on all the trials, on how can we improve the quality of those services. But when it comes to what should we do to improve the financial protection of people in order for them to access those services, I think that is where the intersectoriality and working across with other branches of the university is key. And again, it's not just economists, but it's also the people that shape the public policies, because clearly financing health services comes at the detriment of financing other things, which is the military services and the arms and other aspects of public policies. So what we did in the working with another Lancet Commission, which I had the pleasure and the fortune to be associated with, which was entitled the Lancet Commission on Investing in Health, when we published in 2014, was the concept of progressive universalism, which means looking at how can countries progressively expand the coverage of the services and the type of services that they can provide to their citizens, and ensure that they start first from the citizens that are the poorest, that are the ones furthest behind. And again, this is where the political will is so important, because we have evidence from across the world that, in fact, universal health coverage has been reached in countries very diverse, such as Thailand, Sri Lanka, with income that has not been the highest income in the world. And we have evidence, as demonstrated from the acute discussion in the United States, that countries with the highest, some of the highest income per capita is failing to reach universal health coverage. So the political will is absolutely crucial and important, and the actions that we are taking and the World Health Organization is taking under the leadership of Dr. Tedros, I'm quite confident that they will lead to the kind of collective actions that move the policymakers to invest. And one of the refreshing things that he has initiated has been a collaboration, for example, with a global citizens group, global group of young people that are demanding access to healthcare services and universal coverage in their own country. So universal health coverage, moving it from the best public health concept that we have to offer to a solution for the improvement of the life of women, children, and adolescents. The second concept that I like to elaborate on and then conclude on is the concept of the life course approach to health. This is very tied to the concept of universal health coverage, but the idea is very simple, is the idea of optimizing health at every stage of life and across generation. Why does that matter? Why did it become so interesting? Because there is a host of new studies and new analysis that has revealed, for example, how some non-communicable diseases, including hypertension, are linked to prematurity and low birth weight, for example. How risk factors that start in adolescence, the use of smoke, the practice of physical activity, both the positive factors and the negative risk factors, how those factors in adolescence, they lead to significant impact in our health later in life. And one key element is actually mental health. Now we have data that have been published very recently that has shown that more than 50% of mental illnesses actually originate during the adolescent period. And so ensuring that we look at each stage of life and we try to maximize that health capital we have is very, very crucial. For the first time this year at the World Health Organization, we also launched an adolescent health framework, and we spotlighted a period of life that in the past was considered to be healthy. It was considered to be, public health, we don't really need to look at adolescents because but in truth, what the data we publish and that I'm sure you will have seen, we have 1 million deaths in adolescents every year. And the causes of those deaths are also, they have very strong gender differential, because in boys, adolescent boys, clearly we see mental health and particular injuries and traffic accidents, whereas in girls, of course, particularly in the older adolescent years, between 14 and 19, we see a significant impact of early pregnancy and all the disruption of reproductive health. So focusing on those different parts of the life course and maximizing the health capital is quite important. But it's a concept and an approach that is gaining acceptance, but is really truly not quite transforming the way that the public health thinking and the public health design of system. And that requires, and here is where I'm speaking particularly to the young people, require new energy, require new research, require really truly a lot of thinking and a lot of analysis, working with adolescent and young people, because they have ideas. One of the most interesting experience I had, and maybe the most challenging interview I had from a journalist, was from a 14-year-old girl in South Africa at the time when we were having the Partnership Forum in South Africa. And clearly, she had a very clear understanding of reproductive health and rights issues, and she had very sharp questions to ask. But I think for public health practitioner, the design of health services for adolescents is something particularly elusive. And I will have forever in my mind this group of young journalists among these 14 years old. They said to us, nothing about us without us. And that is a transformation of mind, I think, including for great university like Cambridge, where in some ways we come from the tradition of the studying subject, analysis and epidemiology, but we are not really skilled on participation, on participatory methods. I was so pleased to see at the beginning when you presented the participatory methods. And there is, across the world, I can vouch for it, there is, policymakers and politicians are particularly scared of that approach that involves young people and young voices. To make those young voices count is something that is particularly scary, and especially when we talk and discuss about their ability to make a reproductive health decision. Across the world, this is one of the most controversial things I've worked, I can vouch for it, whether or not the politicians are willing to enable and empower young people to make their reproductive health decision by themselves, without parental consent, for example. This is one of the critical aspects of the work. But even on the life course approach, I think there is interesting work ahead. I was hoping that I would come with a publication, Carol, but unfortunately it's scheduled to appear in December on the WHO Bulletin. It's a new framework that we have developed of operationalizing a life course approach to health. So hopefully I will send it and you will share with the participants. But it's not just a framework, but also we have been very encouraged, for example, by examples of studies like the Australia longitudinal study on women's health, and how this particular study that has studied more than 60,000 women divided in 3 cohorts of different age groups, 18, 23, 45, 50, 70, 75, and have followed them since 1996 when it started. And they were able to have invaluable data about the health and the change of health pattern, the access to health services by women across those 3 different cohorts and during their life. And they were able to influence policymaking, particularly in Australia, but increasingly also more broadly in the world, on a host of issues. For example, like the influence, they were able to assess and measure the influence and the impact of exercise on non-communicable diseases, as we have discussed today. They were also able to assess, for example, the impact of violence against women and how that violence, that physical violence, results over time on mental issues, mental health issues over time. So these kind of longitudinal studies that are looking really at the life course of individuals and what are the measures and the effect, the positive effect that prevent and maintain that health capital. I'm encouraged that we are seeing these, and I understand that also here in Cambridge you are looking at these different kind of participatory research and also longitudinal studies, including looking at the aging of the population, which is one of the greatest challenges for the future that as public health we will have to face. So let me conclude with, I see that I actually spoke longer on the third part. You were not giving me any signal anymore. Let me conclude with a few statements and a couple of quotes that I would like to leave you with. Clearly, when we talk about health across the life course and unlocking the potential of women, children, and adolescents, you will have understood that I remain stubbornly optimistic because I've seen that the world can change, I've seen that changes can happen, and I've seen the need for coordinated, integrated, well-funded, country-led actions at scale. And I'm optimistic that this can happen to achieve universal health coverage across a range of countries, and also that the operationalization of the life course approach to health in the pursuit of the Sustainable Development Goal, particularly number 3, that can happen. There is clearly evidence that this can work. But, and here I quote Winston Churchill. I thought this would be very relevant, maybe not for you, sir, but for the rest of the audience here. He actually said, continuous effort, not strength or intelligence, is the key to unlocking our potential. And I thought this was something that we needed to remember as public health professionals. We have to be resilient. We have to continue the effort. We should not give up, even if sometimes we become frustrated because we don't see the impact of our research or our analysis on the policy. But the final quote I'd like to leave you with is a quote that is my favorite quote in the world, which is from a statement from Africa, and that is from the late Nelson Mandela. And I have had the pleasure and opportunity to work with his wife, Graça Machel, as the chair of the Partnership for Maternal, Newborn and Child Health, that actually took the mantle from Professor Frank. But this is a quote that he has said. There can be no keener revelation of a society's soul than the way it treats its children. And to me, I believe that our society, my own society in Italy, and I've known the society in the UK, we have noble societies, and I remain optimistic that we can do the best to treat our children in a way that we can feel proud. Thank you. Thank you very much.